to go into the main, here we go. Now, hopefully you all see part 2 LRN resources. Is that on your screen? Give me a thumbs up if you have them. Okay, awesome, awesome. Okay, so what I hope to do today, and just to run down the objectives, I'm going to really talk about where you can find the LRN guidelines, as well as not just NPHL guidelines, but other guidelines that you can use to compare to. That would be something called the APHL guidelines. I also have the old blue book, which is a CDC thing that if you've been in the lab for a long time, you might remember, but they've updated that. And I'll talk about that in a moment. And then we want to get into talking about each of these organisms and what their LRN protocol is, and then how to correlate the patient's symptoms and the virulence factors, basically the epidemiology, and correlate them with your clinical findings. What's growing on the plate? What's lactose fermenting? What's not growing on your McConkeys? And then, use even the epidemiology part to rule in or out. That might be half of your trigger points, knowing what the patient's suffering from. But I realize that not many of you might get the patient's symptoms. It's not something that is shared with by the physician in your computer. There are ways you can get around that. We'll talk about that in a second. So I have a list of agencies that you can contact for assistance. There's basic requirements for shipping. If you do think you have a suspicious organism, it does need to be shipped by Category A, and you have to be certified to ship Category A. Category B is an organism that you really just have to read the procedure or maybe review different trainings that might just be about Category B. But it doesn't really have much about classification in there, and I want you, since you have the potential of having a Category A, I want you to be able to know how to do to ship Category A as well. I hope that this fall I can be holding my own personal class. Past years, I've always kind of depended upon APHL to do the training for me. In fact, we always had Pat Payne come here in person, and that's about the only way to train. But in this time of COVID, it's not possible, so we will be trying a class this fall on Category A shipping. And last but not least, you will need to know the requirements of all the CDC forms in case you actually do have one of these organisms. It's just protocol that you will fill out one of these, and we'll talk about it more. All right, give me a second. I think I want to break out here. Now, what screen do you guys see here? Do you see? This didn't work for me. I wanted my speaker notes. Okay, let's start over. I'll just see me. And now I'm going to share the proper screen, which should be this one, and I'll share. Okay, now I can do this. And for some reason, it's still not working. It did for me this morning when I tried it. Okay. What screen are you guys seeing? Are you seeing Laboratory Response Network, or are you seeing like answers? Or just notes? Please, somebody let me know.
It says LRN Sentinel Laboratory Protocol.
Okay, and is it red bullet points?
Yes.
Yes.
Okay. It is. All right.
Yeah.
Well, it just means somewhere my speaker notes have been. Now I'll figure that out after the break here. Okay, so we'll keep going. Now, this Sentinel Laboratory Protocol that we just talked about, we're going to use this to rule out the more hazardous organisms like Bacillus anthracis, Brucella species. There are a number of different species, Francisella tularensis. We will also rule out Yersinia pestis, which is kind of an old organism, and as well Burkholderias. And the two Burkholderias are the Burkholderia mallei and Burkholderia pseudomallei. And as you know, pseudomallei has been in the news lately as being in the United States, which is a little scary because none of us really see it much. And so we don't get used to looking at this organism per se. Well, dang. So it does not allow me to change. Here we go. Aha. Keep slide updated, arrow. So here you go. Now you should see a screen. It's called Laboratory Guidelines. The LRN was formally done by the CDC. However, a number of years ago, CDC did have an awful time in keeping them updated. So they asked the ASM, which is known as the American Society for Microbiology. They are the ones who manage the LRN protocol and have done a wonderful job in keeping them up. And in fact, have redone several just very recently. ASM website does hold these protocol. However, they're very hard to find on the website. So what I have done to make it easy for all of you is to be able just to find it a little more quickly on our website. So this is what our website looks like once you click down to preparedness. Now there's two types of preparedness. There is the biological events and chemical events. Unfortunately, my arrow, is pointing toward chemical, but in reality, you do want the biological events. And it will be this page here that you're seeing now. And there's a number of resources here that we'll go through and talk about, but that's also where the APHL guidelines or ASM guidelines will be. So we'll get through that. All right. The other option you have is something called the bench guide, which for just Nebraska, we have made a much more simple guideline because I know that a lot of laboratories no longer have the full set of biochemicals. So we've geared it down to only certain biochemicals to use. And we want you to follow just that protocol in order to at least eliminate most other possible pathogens. But do know that APHL recently put out a new one that has a little too much in it, but it does have some really good information, which I'm hoping here in the next year, I can combine these two books and make it one so that you don't have to switch back and forth. So the other guideline I want you to know, I mentioned earlier that CDC had something called the Blue Book. We have pretty much scrapped that because so much of it was from like 2004, 2005, very old. So many things have changed in there. And I found it was still being used in one lab probably about 3 years ago. And so I want to make sure that everybody has this on their radar. It's called the Blue Book still, but the front of it is called the Clinical Laboratory Preparedness and Response Guide. I would say print it out like we used to have the Blue Book years ago, but it's 333 pages long. So if you really want to print it out, that's great. It is quite colorful, good to use. I have it printed here, but if you want to save or don't have a colored printer, I would save it on as in a bookmark it on your computer. It is on the NPHL website, but it has a lot of information. I think it's put in clinical laboratory terms, and I think you'd really like this one. And FYI, about half of this book is packaging and shipping. And so we'll be using this book a lot for our class as well. All right, so just to know that everything that's on our NPHL website is kind of like a toolbox. It's got these guidelines on it, be it ASM, be it our NPHL bench guide or APHL bench guide. We also have a list of disease, a reportable disease, but do know that that differs for every state. So our friends from Kansas, from Georgia, they have a totally different list. Kansas, Jesse, tell me, how many pages of organisms do you have? Is it like 1 or 2 pages of reportable disease organisms?
Just one. I believe it's just 1 page.
Okay, that's great. How about Georgia? How many pages do you have? Matthews? Athil Matthews? How many pages do you have on yours? Oh, and he may be off just at the moment. Yes, Nebraska, unfortunately, tends to be a lot longer. It's like 6 pages long. So don't panic. I have also created a couple of quick guides for shipping that we'll go into. And there is also a BT readiness procedure that everybody should have in their own procedure manual. If you ever have a real organism and need the CDC form to fill out, it will be right there on our website. And then I have a lot of articles and case studies that you can share with your staff. Make it an exercise, do a game with it, like a mini drill or something. Things that you can use to do training with your own laboratory. All right, so I mentioned the title or the reportable diseases. This is what Nebraska looks like. And hold on, if I can move this. Yeah, this is what Nebraska looks like. And what I do is it's the whole list. This is what has to be done because it is a state regulation in our state code, Title 173. And in order to change it, we literally have to go to our state unicameral and ask for them to change this. So to make it easier, what we have done is try to color code it as to what organisms literally get sent to the Nebraska Public Health Laboratory or just reported. Most of these organisms are simply reported. You don't have to send to our laboratory. But those that do need to be sent, if it's a potential anthrax, cholera, brucella, it does get shipped as a category A. And there are more pages to this. You'll see it on our website. And why can't I change this? Okay, here we go. I did some shipping guides. There are two shipping guides. One is what we call culture dependent, and one is called culture independent. So what culture dependent means is any microbiology lab that does this package, or excuse me, that does some degree of microbiology. And maybe it's not everything. Maybe they only do blood cultures. But here at this point, somebody's doing a gram stain. Somebody is maybe at least plating it. And sometimes the laboratories that only do blood cultures, if they are limited such that they only plate it and then send it to their reference laboratory, you can still be a part of this LRN guideline. We do gram stain challenges. We do limited sentinel laboratory training. So if you don't, maybe you're not able to rule out Francisella or Brucella because they're really slow growing, but at least you can recognize it in the gram stain and warn your, the whole object is to warn your reference lab that you've got a patient with these trigger points and it looks like this in the gram stain. So any assistance when you send these organisms up. In fact, my thought on this is if you recognize these, instead of sending it to your reference laboratory, I would much prefer you to send it to us as the state health lab. We will rule it out for you. And if we do rule it out, then you can work on it safely if you've saved the organism, or we would be happy to identify it for you. So that's kind of how Nebraska Public Health rules. Just make sure that if you're working, say, in a laboratory in Iowa or any other state, check with how they handle some of these organisms. All right. The ones that are culture independent shipping guys, we're finding more and more laboratories who bring on BioFire or some of the other multi-platform equipment. And then here's a laboratory who's never done any microbiology, but now they're doing this type of testing, and they might get a weird answer. They might get a different answer than what your reference laboratory got. So these are all things that we want you to be aware of, and that these organisms, since you don't do microbiology, but just the trigger points alone of the epidemiology of the patient might be a trigger point. And if we can spare the reference laboratory, have you send it to the public health lab where we can work with it in the BSL-3 guidelines. Or if just to call us and help you, we can consult and to see how significant it is to work with. And then we could make a better decision whether you can still send it to your reference laboratory or not. We're not trying to get your business or your reference laboratory's business. It's just what we want to make safe. Make sure you're safe before you send it out to someplace else. So this is a good guide I would go ahead and print it out and make sure you have it on your stool bench or your BioFire bench, whatever multi-platform that you use. Okay, so then what other toolkits do I have? Okay, I talked about something called the BT readiness procedure. If you do not already have this in your own laboratory or something similar to this to say, what do you do when you have a fire? What do you do when you have a possible bacillus anthracis? What do you do when you have a really unusual organism that is very hazardous to work with? Neisseria meningitidis, as we learned. You should have something. What they have done, the CDC, is actually developed a template in which you can use, and you can fill out your own name of your facility, put your title into it, print it out, and put it in your laboratory procedures. And there you'll have to make some notes as to what is different or what phone numbers they should be calling when they think they might have a hazardous organism. So please consider this, incorporating it into your laboratory manual, and also know your accrediting requirements. Are the inspectors going to want to see this kind of information? I've got just a few more, and then I'll ask for questions. I want to go through some of the different, let's see if I, whoops. Biochemicals. One biochemical we use that's very common in the laboratory is called the catalase test. It's just one of the basic things that I think most laboratories still do. It's very rarely do I have to supply, but some laboratories, if they do biofire only, may not normally do this type of testing. So I provide them with the catalase, and we do not recommend the slide catalase. Now, granted, most laboratories still use the slide catalase for what am I trying to say? Streps and staph. And if you do, just think about it this way. It is something that we've done for years that way and probably never had a problem. But in the case that you've got one of these organisms, we would not want you to be doing this on an open bench top or doing it on the glass slide. We would much prefer you do what's called the tube method. And I don't always like the tool methods that you use or that you see being taught, because some people what they'll do is they'll put about 4 or 5 drops of the hydrogen peroxide in a tube, and then they stick their organism that's on a stick right into that fluid. And yeah, that's the same story. You've got bubbles that are coming out because you have not capped this yet. My recommendation is that you go ahead and kind of smear the organism on the side of the tube, these little polyurethane tubes that you can use, and cap it first. Dispose of the stick or loop or whatever you're using, cap it, and then tip it. Now, I had this pick tipped to the side. It's just to get it to fit on here, I kind of put it upright so you could see the bubbles. But that works the best, and that's still what I'm recommending in the biosafety cabinet for anything that you're going to test the LRN for. Okay. So obviously you want to make sure and do it in the biosafety cabinet. We'll be talking about the tube motility as well, and that it should be done. Tube motility, let's talk about that a little bit. The tube motility can be different. Most laboratories don't even keep it anymore. Some laboratories do, but they might purchase the Rimmel brand, or I know that there's a few other companies that have it. Please let me know if you have another company besides Rimmel. I want to see if anybody's using anything else. Nope. Everybody have Rimmel? Does anybody use their own? No. Okay. All right. So if you're making your own, we have something that does not look cloudy like most of the commercial ones. Gives you a nice clear media, so that if you have an organism that is not motile, you'll see a very distinct streak. If you have an organism that's very motile, it will be motile throughout the tube and looks very positive. So it's harder in the Ramel media, but you can use it. Some Ramel medias have a indicator like a TTC to help you see it, and that might be just as easy for you. But I know that people who do not have experience with these tubes don't often like that. So you can just see what your laboratory likes best. Try it out. I'm willing to share that recipe if any of the other states would like this recipe to share with their laboratories. A couple other comments. Urease is another tube that some laboratories do not use anymore. There is a urease disc that you can use. The disc I have shown here on the top right, that's obviously beta-lactamase, but you can use that disc, urease disc too. But again, for the laboratories that might not have any other biochemicals or QC organisms, they may not want to do this, and or purchase this media. But yet it's integral to all of our flow charts and used especially for our brucellas. So they can be very useful. The other test that laboratories have is oxidase. I find oxidase can be very deceiving, and sorry about that. And some laboratories have a hard time with this. If you use a lot of organism, it might work. If you don't have enough organism, it might not turn purple. There is a trick to the trade in doing oxidase. If you try to put the organism in the very center, it might be negative, even though it's supposed to be positive, because that's where most of your fluid is. And you could flood out your organism. You won't be able to see the positive. I've had other laboratories who were negative and had so little organism in it and didn't let it sit the required time, and so they called it negative. My experience is to take the organism, make sure you take enough, start from the inside and literally streak to the outside. Of course, it does it every time. Streak to the outside of the circle. It seems like this is the best area where it diffuses sufficiently, the reagent, and that will give you your best true answer. And then, of course, beta-lactamase is a test that works differently for different organisms. Staph aureus takes about 15 minutes to turn, whereas some of our Haemophilus only take 1 minute to turn. So be sure to read the procedures and use the tests correctly. That's why I recommend when everybody takes on the LRN protocol, that every time you do this LRN protocol, that you do any test that you do a positive and negative test with it. Hopefully you'll have the QC organisms there that you can do these, and both a negative and a positive, and you have something to compare it to, because sometimes it's just not that easy deciding if it's positive or negative. All right. I also make another comment, the spot indol. There's two types of indols. You can just have the regular indol that's used in most laboratories that will turn positive when read. But if you're using a spot indole that is known as cinnamaldehyde, do remember that your positive is going to be blue. So don't get those two mixed up. Don't accidentally call it negative or positive, and when it should have been the other way around. So for the old procedures, if you still have them laying around, you might see some indication you should be doing India inks. We used to do those with cryptococcus or some sort of wet prep to look for motility. Don't do them. Those are such a no-no in biosafety terms now and in laboratories. Those have totally been discontinued by the CDC because there's such a risk to your laboratorian when they want to do that hanging drop or look for motility or a capsule. It can't, you'd have to take it out of the biosafety cabinet and put it on your microscope, and that's just not cool. So, all right. Did I have any others? So, any questions? I'm going to open it up now to the audience, and feel free to ask questions about these biochemicals. Let me know if you don't have them in your laboratory or how your LRN protocol works. Any questions? Let me check. I am going to check just in case there's any questions. Manila, I see your one page for Great Plains. I bet that might be the shipping one that you have. Go back and double check if that's the shipping or if that's the true full one or Title 173. That's what she was referring to. Okay, so then I have a question. Why is slide catalase not recommended? And excuse me if I didn't describe that well enough. Well, on a slide, if you think about it, I have trifocals on because my eyes are bad enough that if I don't use these, I can't see without my glasses. So here you are, you're looking at your slide. And what do? You actually really are looking for bubbles on that glass side. Well, those bubbles indicate you've got aerosolization. So right outside of that, you're going to have aerosolization, possibly carrying the organism itself right into your nose or your mucous membranes of your eyes or ears. So it is not safe. People have been known to get organisms from just the slide. That's how laboratorians become carriers of MRSA, even though it might not affect them. It's been known that laboratorians have a much higher carrying case of MRSA because of that slide catalase. So very good question. I'm going to leave it to you to do the risk assessment. How safe is it just to do the slide catalase? And if everybody signs off, when I say slide catalase, I'm talking about with streps and staffs. Now, then you can write your procedure that way and have everybody's that's doing the risk assessment sign off of it. But if you're suspecting any one of these organisms we talk about today, there's no ifs, ands, and buts. Those should be done in the tube under the biosafety cabinet. So thank you for that question. All right, any other questions? Did I miss anybody? Oh, Jason, I do see your camera is not working. That's fine. Are you able to see the slides? Probably not, even on your phone.
Yeah, so we're on the computer now and we can see everything fine. We just,
okay.
for whatever reason, we can't.
All right. Well, the reason I don't hand out these as copies to you beforehand is once we get into the case studies. We won't, I don't want to give away the answers. So I will give it to you all afterwards that you can use it for your exam later. So, okay, good. If no other questions, because it is already, what time? It is 1:11. You've been at the Zoom for over an hour. I want you guys to, we're going to take a break. I want you to stand up, do some exercises, quick, take a phone call, run and do some procedure that you need to do. Yeah, stretch the neck. Do your exercises. So I think that's so important. I'll try to give you 2 breaks through all of this. How about, since it's 1 o'clock or 1:11 Central Time, let's be back here at, let's say, 1:20, and we'll get started again. And that way, we're going to start in the case studies. I will be doing Bacillus anthracis to show you guys all, and then all the organisms you get to do, well, at least 3 of them. So be on board, and I'll show you how to do the first one, and you guys get to do the rest. We'll see you in about, how about 1:22. Thank you. Just leave your computer on, and that way you don't have to scroll back up. I am at a Zoom class. I'm actually teaching this afternoon until 3 p.m. period. If you need any help right now, feel free to call Emily or Pete. Their numbers on our website. For those of you who are back, can you see a screen that the original screen like we were talking before? This one, however, will say trigger points. Okay, perfect. Yeah, so I finally figured out how to do my speaker notes, so I don't forget to tell you anything. All right, any questions about things you might want to bring up before we do the case studies? Is there anything that you're questioning what I talked about? Feel free to unmute and let me know. I hope you're all able to grab lunch at this point too. If you didn't before, maybe you should be getting hungry by now. So. All right. Marissa, you are my one lab that may see these organisms more than any other lab here. So you probably have heard about and follow the LRN before, huh?
We've had multiple suspect tularemias, and since I've been here, there's been several Brucella species.
Yes.
So,
you know, it used to be that we would get Francisella, couple, maybe a dozen every year, maybe half a dozen. And I had never seen a Brucella until maybe 3, 4, 5 years ago. Holy smokes, now we're getting them yearly, if not multiple a year. So, yeah, it's always interesting to find out how or what happened, at least for patients. But then you see animals, and do you know how they come upon Brucella? Probably from other, wildlife, I assume.
yes, and we are able to refer a little bit to the vet notes
Sure.
that come through. So that's helpful to us, at least, that we can see what some of the symptoms are, or
Sure.
that epidemiology perspective.
Yeah, makes sense. So, yeah, I've always loved your new lab. Hope
Beautiful.
that you got it broken in by now, right?
Oh, yeah.
All right. Now let's see. I do have 122. I was just asking if anybody had any questions. We could go through them before we break in here.
I was just
If none, I will.
This is.
Did I hear something? Or was
Yeah, Mary Lanning.
yes.
Where is, you were just speaking to somebody else at another laboratory. Is she at a veterinary lab?
Yes. So Marissa is from our UNL vet lab. So, and they do send us specimens on occasion just to confirm. So they have to walk through the whole LRN protocol on a, I can't say regular basis. So, Who else has had to work on the, or has actually had a suspect organism? Has anybody else in the group had
We
to
have.
work on an organism?
We have just about 3 weeks ago.
Laura, really?
We had
I
a
didn't
Francisella.
hear about this one.
We had a Francisella tularemia. We've had several of those cases since I've been here.
Wow. Okay. Yeah, it's been bad this year. So, yeah, and you've got good experience behind you too, many years of microbiology. So, but you always hate to see those come through. So, good. Anybody else have one? All right. All right, well, let's just go ahead and get started so we can get through all of these. Like I said, I'm going to go through a few things. I'll actually do one case for you, and then I'm going to probably have you all try your own. I wish we could have used breakout rooms today, but I was not able to make that happen because then you could work as a team like I normally would in your wet labs if I were to come and to teach this. But don't hesitate to give what answer you feel best. They're not graded when we go through the case studies. It's just a learning option. All right. So the trigger points, if you ever look at one of our lists of trigger points in those bench guides, you'll see that the list is quite long. And I used to try to teach all those, but now it's just impossible to remember everything. So there are two that I have here in red that I want you guys to remember, write them down, post them, whatever it takes, because these things will happen and you have to be suspicious at that point. So let's say you have an organism that you had a non-hemolytic, well, you saw gram-positive rods that were very boxcar shaped. We'll talk about that. And they're non-hemolytic on the, well, boxcar shape in the gram stain and non-hemolytic on the plate. Those are ones that should be just immediately thought of as possible BD organism. You should no longer be working on the open bench with those. Before you do any other gram stain again, whatever, it should be worked on in the biosafety cabinet. If you have a organism that's not growing, and it happens on occasion, doesn't it? It may take, you have no growth at 24 hours, you didn't see anything in the gram stain, and then lo and behold, here you have something growing at 48 hours. Don't even try to do the gram stain on the open bench. Don't try any manipulation. You should just walk straight to the biosafety cabinet and do what it takes to properly gown up and then to have all the supplies ready to do some working on via, whatever biochemical reagents you need. All right. So some others that we'll talk about eventually, there are some organisms that grow better on chocolate than sheep blood agar. That might be at 24 hours, but Haemophilus grows just as well on blood it grows well on chocolate and shouldn't be growing on sheep blood, Haemophilus. But if you see something growing really well on chocolate, think it's a Haemophilus, and then see a little growth on sheep blood, be aware. Just be aware. There's some scenarios that might occur, might help that happen. Gram-negative rods, if you have no growth on McConkeys, because as you know, most enterics, all your Enterobacter will grow on the McConkeys plate. So anything that's not growing on McConkeys and you think is a gram-negative rod, or the original gram stain showed it as a gram-negative rod, you should probably not be working it up any further. Don't put it on your Vitex or anything like that in the open laboratory. First, go in, do the LRN protocol if you're able to rule it out by doing just a few biochemicals. Then you can feel confident in putting it on our automated systems. Excuse me. Okay. Also, this is the other big one. If your direct slide shows any type of gram-negative diplococci or coccobacilli, again, nothing should be done on the open lab. That particular culture should probably be even taped up, especially if it's a spinal fluid or any other sterile site. And that will notify the people working on the benches that they, write on the plate, work up and be biosafety cabinet, do anything, leave them a big note. Just say, we think this looks hazardous on the original gram stain. Please work in biosafety cabinet. Now, what you're thinking of with the gram-negative diplococci versus coccobacilli, we'll go through in just a minute. So the first thing you're going to do is try to think about some of the initial trigger points. Well, I just gave them to you. Sometimes, like I have said, some trigger points might even be seen in the symptomology of the patient. So if your computer site, computer program, whatever you use for your LIS, if it does not have the patient's symptoms on there or notes from the doctor to give you a clue or hint, you need to talk to your IT because it usually can be programmed in. I know when I was at CHI, they had Cerner and nobody ever used those particular screens. Well, I discovered that I myself had control of that I could bring up the patient's phone number, which a lot of times working on weekends I needed. I could bring up the physician notes. I could bring up any other symptomology just on that patient demographic area of my requisition that I was working on the computer. So if you do not have that available to you, please talk to your IT people. Because those could be definite trigger points. So with that trigger point or what you're seeing in the gram stain or seeing on the plate, if you start having a hint that you might have a suspicious organisms, we have what is called a workup table. It's usually a summary page. And we've got that for gram-positive rods, for gram-negative rods, and I'm not sure if I shared the other one. No, well, I'll show you the next page is usually gram-negative coccobacilli or gram-negative diplococci or small rods of sorts. So this way, at least you can look quickly, look at what you have, the gram stain, compare it. If you actually have growth, you can look at that and see if anything fits, and you can maybe even rule it out just from that. So for instance, if you have a gram-positive rod and you look on the summary page, there's a couple of things here. We want you to be aware, does it fit a large gram-positive rod? We call it box card shape. Maybe in chains. Bacillus anthracis, chains quite frequently. If you see a capsule, at least in the direct specimen. So if you're taking a gram stain from a plate, obviously it's going to lose its capsule. But in patients, you're going to see patients or animal, a live being, if you're taking a specimen, that may still be visible, and you'll see it as a what we call a well, is it here? Let's see. Yeah, a clear area around the rod in the direct specimen. I'll show you examples. Or you see some subterminal or centralized spores that don't have significant swelling to the cell. A lot of bacilluses have weird shapes to them. And if they look like lollipops where the very end of the cell is grown large, then you know that you can easily rule out Bacillus anthracis. Or the thing about Bacillus anthracis or any of the other bacilluses or anaerobic organisms, gram-positive organisms like Clostridium, they're going to decolorize very easily. Nothing to do with your technique in gram staining. It's just the organism itself that tends to decolorize very, very easily. So if you have a gram-positive rod, they have a black scar reported on your patient demographics, might be a hint to look at what you have on your plate. Do you have really good growth? I mean, bigger than what it should have been. Let's say it was subbed the night before, you look at it early the next morning, it's only, I don't know, 12, 15 hours old. Is it really growing nicely when most would be just pinpoint tiny at that stage? Are they convalescent, irregular edges? Are they ground glass appearance? Do they have projections to them? I'll show you what these all look like. Or there no hemolysis? That's a definite yes. And then are they tenacious? Do they stand up like egg white when you touch them? Hopefully you're in the biosafety cabinet. So, and that you have no growth on chocolate or McConkey. So this whole summary page can help you out. Now, to know what biochemicals you need to do, if your organism is fitting all of this on this page, then you're going to want to go to the page on Bacillus anthracis in order to rule it out. And that's what this next page will be. It will walk you through some more of the clinical part. If it's a skin lesion, sputum, spinal fluid, rarely you'll see it in stool. If it's chaining, if it's large, boxcard, decolorizing. Now, usually again, one of the clinical things is you don't see spores in patient specimens, but you might see encapsulated organism, and that's a sign of bacillus. So we'll take a little bit further look now. Oops. That's just to kind of show what the gram-negative rods look like. The gram negatives we'll talk about at a later point. So let me just go through some of these other things. Yeah, and so what I was doing is kind of going some protocol of the other cases. We'll talk about them again. So what I was trying to say is, yes, for gram positives, that's how I did it for anthrax. But if you have a gram negative rod in your case studies, which you mostly will have, that you'll need to go to either the gram negative side or to the gram negative. Let me start over. At either the full gram negative rod side where they look like true rods, or if they look like gram negative coccobacilli or gram negative small, very tiny rods. It's just hard to tell at some point. So you can read through, you know, on the summary page, if you think yours looks like a gram negative coccobacilli, read through the three areas that might be suspicious. See if those areas fit. And we'll talk through it, but I'm going to have you try it first with your own case study. And here's on the gram-negative coccobacilli. Here's some of the clinical sides of it in sudden onset, if it's in blood, lymph node, very tiny, weak staining, difficult to even see individual cells, then you might have a Francisella versus a Brucella, which causes a lot of different types of outcomes. Clinically, it might have a lot of different things wrong with the patient. And the bone marrow, the doctor has asked you specifically for bone marrow to be put in blood bottles. And they still do that sometimes because they know the bone marrow is very sterile, and they know that even if there's one organism, it will be picked up if put in a blood culture, because that blood culture media will allow it to multiply. Whereas if you just have one organism, putting it to plate might mean you might miss it. That one organism might not be able to grow significantly, and you don't have enough colony to dig it out with. Burkholder Mallei is also going to be very small, and it again is going to look very different and grow very, very differently on plate. So do check your summary pages when you have these studies, these case studies that we'll be sharing with you. All right. So what I'm going to do is, again, like I said, I'm going to walk you through one scenario, which is Bacillus anthracis, but this is how it would work in a clinical lab. You're not going into these thinking every one of these has Bacillus in it or gram-negative rods. It's when that trigger point hits, essentially. So let's say you had a blood culture, it flagged positive, and you look at it closely, look at your requisition. It flagged positive even 8 hours after collection. So it probably means nothing to the night shift people who are doing the subbing. They would just make sure that they sub it in the biosafety cabinet, which is required for all blood cultures anyway, to be sure that it's subbed in the biosafety cabinet. And it's probably subbed to blood or chocolate, at least, if not all three, blood, chocolate, and McConkey's, depending upon your protocol. So yeah, that is something that, how would you know it was 8 hours after? You'd almost have to look at the requisition, wouldn't you? The patient demographics to see when it was collected and when it turned positive. Most organisms don't turn positive until 16 hours, 24 hours, and then might even take 48 hours. But this is the one situation where you're going to have a really fast grower. So let's just say, let's pretend in this case study, you are now assigned to the blood bench. The next morning, you're going through plates. Think about how you look at your plates as you do your bench. Do you open all your plates first and look at what's growing and just start working them up before you look at the requisition? We don't recommend that. In fact, what we recommend is that you, before you even open your plate, that you literally go to bring up that accession number, look through all the LIS demographics prior to even opening the plates. And you're going to look at a couple of things. Look at, what kind of symptoms your patient has, and see, this is where I built it in my Cerner to be able to see the patient's symptoms. I can look and see how old the patient was, because obviously some organisms probably hit older people versus younger ones. But I also see his history. that I have a farmer that now the physician thinks he has food poisoning because he's throwing up or something. So you also want to look at where, that patient is at. That patient is in the emergency room. Now, is it significant in the emergency room? Yes, probably because he's pretty darn sick. If he's just in the clinic and complaining that he has, stomach ache, it might not be as significant. But if they come in with a black eschar, as I'll show you, it might be significant. So this is where usually within the requisition, you'll see that it's always developed or reported when the patient had the specimen collected and then when it was received in lab. So here it took about an hour to get down in lab. So about 1300, which is about 1:30 in the afternoon, it was collected and received. And then if you notice about 2000, which would be 10 at night, or no, I'm sorry, that's the year, 2145, that would be about 11:45, it turned positive. Well, all right, so you know that even within that time, there was a very short amount of time, 8, 9, 10 hours, and most organisms don't turn positive. So that should be your first trigger point right there before ever doing the gram stain. Other than that it was a farmer with food poisoning, that might be a trigger point too. Okay, so I am pretending that you're the laboratorian working on the bench now, and normally the evening shift has done the gram stain, but I'm going to have you practice reading out that gram stain. So let's say this is what the night shift saw. What would you call that? I mean, at first glance, you probably would call that gram negative. If you had some experience, however, and saw that there was large gram whatever organisms, then you might say, this is too large for a diphtheroid, or too large for lactobacilli or something like that. And if you had enough experience that you notice where these arrows, your green arrows are, that they seem to have a clearing around these organisms, that would be encapsulation, which is what we read on our summary page. Now, more than likely, we don't have organisms that have spores, because this organism came from the specimen itself that at night, and not from the plate the next day. And some might say, well, yeah, but I see little spores here. Well, is it the spore or is it the organism dividing? So you have to make that decision too, as to what's happening here in this gram stain. So again, early on with this organism, we have a couple of different trigger points to read. What would you consider? Well, number one, it's a sterile body site. You have blood culture, which we have here. But if you had spinal fluid, it'd be the same story, possibly. The early trigger points here. You have rapid growth. So what you're doing is you look at the plates right away in the morning, and here you've got growth, and you'll need to maybe think about this. Do I want to work with this organism on the open bench? And if I have that rapid growth, shouldn't I go to the biosafety cabinet? I know some people always hated that. They just thought that it's a waste of time to do it, to stop what you're doing, to take it to the biosafety cabinet, rule it out, and then come back. But I'll be honest with you, it's super important that you do it. Well, we don't see much Bacillus anthracis, but who knows if it couldn't be like Brucella or this Burkholderia that we're seeing more and more in the United States now. we could see more Bacillus anthracis as well. Large boxcar shapes, and then also easily decolorized. So yet, if you were the person reading out the night before and you're just a generalist, it's an easy mistake to make, to read it out as a gram-negative rot. But somebody working the day, they might more recognize that these do not correlate, that what is growing, you haven't even opened your plates, but you can see, good growth through the lid, even though there's condensation. You can see it through the lid that it is a very large growth on blood. So, what do? You want to do another gram stain to confirm it's not gram-negative rods, but you shouldn't do it right on the bed or bench side. You should do it in the biosafety cabinet. Okay, what are you going to see once you open up those plates? I wouldn't even open the plates, I think, until you get into the biosafety cabinet. There was a period of time where the CDC said that even opening a plate, even though you had other organisms, you had staph and you were working on that, and then the next day you had maybe a brucella pop through, or you had and you just didn't see a bacillus, maybe there's only one colony of it or something. They would say if anybody's opened that plate, culture plate, lifted the lid off, that they were exposed, even if the lab had not touched it. Well, I don't know, that's kind of one of those fine points that we could argue about. I mean, is it really true that an organism can be aerosolized once opening the plate? But do you know if this plate had been dropped beforehand? If that's the case and you pick it up and open, yes, it could be aerosolized. So whatever the case, that's what the CDC is recommending. Don't even open the plates until you get into the biosafety cabinet, if you can recognize those early on. Okay, so again, what trigger points do you see from the plate? Rapid growth, colony morphology, looks rough, non-hemolytic, and irregular flat. And let's look at that again. Rough, they call that kind of a ground glass look. It looks, what's the word, where it kind of looks pearl-like. So it really is kind of fluorescent, almost. It has commas to it. Bacillus anthracis commonly does this Medusa head look, where it has projections of commas to it. That will happen usually on the more isolated organisms that you'll be able to see that. So any of those trigger points definitely should be worked up. So what's your next step? Obviously, if you see any of those, just looking through the plate, or if you accidentally open it up and don't recognize it until you've started manipulating the plate, whenever you get the first hint that it might be a Bacillus anthracis, just take your work and go into the biosafety cabinet. More than likely, you'll want to repeat the gram stain. And let's say when you go to repeat, it's not going to look the same as you saw before in the direct gram stain. It's going to look maybe like this, where it's gram positive, or it might be gram variable because it's starting to decolorize. But you also see these spores, and the spores, you can very definitely distinguish between what is the septa of the two organisms splitting, or whether the spore, it's a true spore, and it's centrally located in this cell, or subterminal, they call it. It's not producing like large lollipop looks. It is chaining very well here. Truly be afraid if you see something like this in your gram stain that you've repeated. So in this case study, we show gram-positive rods, possibly decolorized, subterminal spores where there was no significant swelling of the cell. Again, pointing back to some of the bacilluses that have different looks to them, and in some of the cells kind of start looking different, multiplying in size. And then of course the age of the cell, the longer that it incubates, the more spores you'll see with age. All right. So here's a couple pics going back to our summary page again, and then going to the actual gram-positive page. Again, comparing notes. Is this about the same thing you're seeing? If there are not many organisms in there, it may be like this center image where there's only one or two. And it's really, really hard to judge whether it's in chains or not. That's going to be virtually impossible to decide. So you might still take it into the biosafety cabinet and do some testing with it. Do the biochemicals that the LRN recommends. We've talked about rapid growth, non-hemolytic, well-isolated colonies that are very large, and then that Medusa head look on it, or a ground glass appearance. Another real good trick is just to touch the colony. Well, and you'll be touching it anyway when you do the two biochemicals we're going to ask you to do, but notice that colony. Is it acting stretchy? Is it kind of sticky, like it won't let go of your loop? Does it stand up like beaten egg white? That it just means that that could be a Bacillus anthracis, because that's exactly how they look and act, somewhat tenacious when you touch them on the plate. All right, so then going on to the next page of the bench guide, you'll notice that there are two things that they recommend. And that is to, once you've ruled out everything else, like it's not beta hemolytic or it's not chaining and such, if all of yours fit this protocol, and you should be in the biosafety cabinet, they would like you to do that tube catalase, and then also to do a tube motility. Catalase is easy to do. You'll know your answer in 5 minutes. Whereas unfortunately, this tube motility does take overnight growth. And that may be what you have to do. If your catalase is positive, then you will have to go to your tube motility. What they recommend is taking that tube motility out. Don't let it come to room temp. Do it cold, because that's the best way to keep that line straight, is to inoculate it when it's cold. And then incubate it, and only go about 2/3 of the way down so you can see if it's your streak or if it's something else. If your catalase is negative, most gram-positives are going to be catalase positive, but if it happens to be negative, then you can totally stop where you are. But once again, I'd recommend that you have a positive and negative control right beside you to make sure it really truly is a negative, that something hasn't happened with your tubes, and your tubes are not working right, or your catalase is not working right, I meant to say, and that something happened in the meanwhile to your reagent or whatever. So you get a false negative is what I'm trying to say. So with that positive and negative controls there, that will confirm that it's a true negative, and you can rule it out and not have to go on to the motility. But if your catalase is positive, move on to the motility, incubate at least 16 hours to 24 hours. And if it's negative or questionable, that means that you cannot rule out bacillus. Why? Because most bacilluses are going to be highly motile. They are going to diffuse through the whole tube. There really should be no question. Now, some of the other organisms going to be questionable in the motility when we have, if you do it, but not Bacillus anthracis. It's either positive or negative. So it really shouldn't be a hard decision. But if it is, that's why we say or questionable. Please contact your local health department, talk to them, walk through it, see if it really has to be sent in to your public health laboratory. All right, so I am also going to let you guys know that there are a couple of other situations, things that aren't perfect, but might still lean you toward Bacillus anthracis. And that is, there are some misidentifications. If you are a laboratory who does not do the gram stain and just takes organisms and puts them straight to the MALDI from the plate, which is, I have to warn you, is really a no-no. You should be doing all gram stains first to confirm that it is an organism that you can rule out before you put it on the MALDI. But if you accidentally put it on the MALDI and you missed all the trigger points and you start getting IDs as Megatherium or Bacillus, other Bacillus species, or something really weird, I think that you should still consider going back and doing the LRN just to confirm it's not a Bacillus anthracis. So this whole page here comes from the APHL book. They go into quite a bit of detail as to what biochemicals to do, some additional biochemicals you can add, and what the morphology can look like. All right. They have a pic here, gram variable. They have some pics of the plates themselves. This is the APHL book that is used. They also talk about another real deceiving bacillus organism that can be misidentified. So there is something called Bacillus cereus, but it's called the biovar anthracis. And what makes this one so difficult is you notice that the biovars, if I can show you, it'd probably be better to do it this way. If you notice hemolysis for anthrax is negative, but Bacillus cereus is positive. So that blows out our whole theory that you can rule out Bacillus cereus because you're still thinking it's a possible Bacillus anthracis. You still have to do the motilities, and they're not going to help in the rule out. What's going to help in the rule out is some further testing that your laboratories don't do, but your public health laboratories might do. Some penicillin testing, but in Nebraska, a lot of my laboratories don't have bacillus anymore, or excuse me, penicillin, or do any antibiotic testing anymore. So that's another tough one. All right, so and they say that capsulated, but again, clinical laboratories usually don't work this up. So how do we know if it's this one instead? We always, in the recent past, have bet on the facts that the BioVar, the Sirius BioVar, has only been seen in goat strains in the Democratic Republic of the Congo, so the DRC, where they see Ebola too. It's never been seen in the United States. So right now, we choose just to follow this guidance here, which is the same as pretty much these in the APHL book. But if you know your patient has traveled to any of those areas, that's one thing a physician really needs to be asking is those travel questions. They are going to be hopefully reporting that this patient was in the DRC. Then it might become an issue. So other things that could be misinforming is the fact that Bacillus anthracis can look different sometimes. It just depends upon the age at which you look at it. Maybe either very young or much older, it starts to deform. It just doesn't look like what you're hoping. It might have very centralized, smooth colonies on it, and only the outer part of the colony looks glass, like a ground glass look. So anything that is suspicious, please do stop, work in the biosafety cabinet, call your public health laboratory, do the 2 LRN reagents, the motility or the catalase first and the motility to see if those are of any help. So let me go through real quickly, and that's what I'll do after each of your case studies. I will go through the clinical presentation of each one so you know what to look for when the physician shares the symptomology with you. So in the case of anthrax, this is a zoonotic disease that you can see in cattle, sheep, and goats. So our friends at the UNL lab, a vet lab, they could easily see this, but to their assistance, I think a lot of your pathology, what do they call it? Your vets, they are definitely going to notice what the skin looks like. They might see the eschar or the other things that an animal presents with. They probably have more trigger points than we do just with the plate. So, yeah. Tony, I know, Tony was I'm looking at the chat. He has a chat list or a chat comment here that CDC still considers an open plate to be an exposure. Granted, yes. And then our Marissa says that the pathologists are really good about sending it for GBR or PCR before they even suspect the anthrax. Yeah, that makes sense. And that's because they can recognize it from the animal itself. But even if you don't have those particular trigger points, just seeing it on plate hopefully is good enough to give you those trigger points. So there are 3 forms of clinical presentations. It can be cutaneous, where you start seeing that eschar on the skin. It can be from inhalation. We'll talk about that briefly. And then even gastrointestinal, which is the worst type of anthrax. Inhalation is probably what we saw for the laboratory, what do you call it? After 9/11, when they had the anthrax scare. that was also from inhalation. So those are the three kinds. I'll go through them very quickly. Oops. Okay, so here is just an example of cutaneous. It's the most common form. It's just that you might have a spore, like a rancher who was cutting up a cow, didn't know that the cow was infected, might get it in his skin, especially if he's got, cuts in his fingers or his cuticles. These spores will get under the skin and start infecting. We've also seen it in wool leather, people who work with leather, people who work with contaminated hides. There's a great story, one of the case studies that I have about Bacillus anthracis is an Indian powwow that happened in the Indian tribe that was giving the exhibition of their dances, used the old hides on their drums. So unfortunately, one of them became contaminated, and that particular event, a number of people became positive that day because they're beating on the drum. So what does that do? It aerosolizes through the whole crowd, those bacillus spores. All right. So incubation in a patient could just be a matter of hours, but then again, it could be that they got so little spores that it might take a couple of days for up to 7 days for those spores to really show themselves and the patient start showing symptoms. But if they do start showing symptoms, it's usually starting with a skin ulcer that then starts becoming bigger and bigger. First it's just a little vesicle, and then it starts turning black, and then it becomes bigger. The unfortunate thing is if it's not treated or discovered, this can spread very quickly to the blood, to the respiratory system, and the patient gets into respiratory distress even within 24 hours. And there's even a 20% rate of death, which is really pretty low if untreated. But if it's treated, it's very rare. And the thing we want to remember is that, especially back in the day when there was the anthrax scare, it is not contractable from person to person. You cannot have a patient in the hospital and the physician getting it, or the nurse, or whoever works with that person. That the patient is not able, it just does not give out enough spore for it to take effect in the physician. And back then, they were so scared to death, nobody would see those patients. So they wouldn't even accept them into hospitals. So do remember that this patient will not spread that organism. Now, anthrax is a gastrointestinal disease, and that's really where they somehow have consumed the spore. It could have been through contaminated food, contaminated water, and what's going to happen is it's going to have an intestinal eschar similar to that anthrax cutaneous lesion, but it's going to be indwelling. So it's going to be in their intestinal tract. It's going to be nasty. They're going to have vomiting, fever, abdominal distress, obviously, if it gets this bad. And it's really bad, too, because it generalizes into a toxemia, and the mortality rate can be as high as 60%, even if there was treatment. You can have pretty high mortality. So it's a nasty type or way to get the disease. We just want to make sure that the farmers are not butchering their own cattle, and then they may freeze the meat, but it's still going to freeze the spore. Obviously, the spore is going to be held, and then when the meat is undercooked, then they may possibly come down with this organism. So this is why I don't like my meat rare or even, medium. When I go to a steak place, I usually have mine well done. So I know it probably doesn't taste good then, but that's me. Okay. Let's talk about the last one, which is the most lethal. It is however, we think what will happen in biocrime. And it was what we saw back in the day after September 11th. I think they used to call it a Amerithrax because it got to be pretty scary for a while. So normally when the organism is naturally occurring, you can only get up 8,000 to 40,000 spores in a person. It takes that much, even though that sounds like a lot, it probably isn't much, but it takes some volume for naturally occurring diseases. But if you have somebody that weaponized this organism like we think happened in the Amerithrax incident, well, the weaponization, what they do is somehow they mutate the organism so it's smaller. It can enter the cells of the lung cells a lot more quickly. It gets into the body much more more fast than ever. So this is why we saw people opening those envelopes with white powder who died. There were several people who died in that whole incident. It was really a sad thing back then. We learned a lot from it. These patients were very sick and died of abrupt distress within even 24 hours. And there were very high fatality rates, even with appropriate antibiotics. So these particular patients, again, it wasn't the person-to-person transmission in the hospital. It is what they got through envelope with white powder. It was a number of other things that happened too. So if you look back at that time, it was the postal system that it was being transported through. 11 people had cutaneous, 11 people had inhalational. But if you think about it, there were 350,000 isolates sent to the public health laboratories. There was also over 10,000 environmental specimens that were sent through envelopes in the post office. They may not have opened the envelope, but it had just saturated the whole post office that several postal workers came down with it. It also went to the Washington political buildings or the Capitol and the Pentagon as well. So we had over 100 EIS field officers working on it. We had 32,000 people who received prophylaxis either in the laboratory because they were so worried that they had anthrax and they didn't work on it in the biosafety cabinet. Back then, so you think about it, in 2001, the LRN process did not even come out then, except maybe just a couple of labs. It was a brand new thing then. But I tell you this, the FBI, CIA, and APH all had these big concerns. So they started talking about the LRN process. They had taught one or two of the big laboratories. And thank God, one of the laboratories that they had first trained was one of the first laboratories that identified the whole anthrax situation. So I think that if it weren't for that training, it could have probably taken a lot longer and a lot more people would have died through this whole process. The lessons that were learned through the Amerithrax that a majority of the negative specimens that really were sent to the public health laboratories, because at that point, everybody was sending gram-positives. They didn't realize that there were trigger points that they could do themselves to rule it out. That if they were hemolytic, they could rule it out. If they were motile, they could rule it out. They just sent everything, which really, truly overwhelmed the public health laboratories. So in other words, lessons learned, the rule out and refer guidelines really do work. They save a lot of money, they save a lot of time, and save a lot of talent too. So any questions about the things I have just shared with you? Let me bring up my chat again. Yes, Tony does share that it was 1999 when the LRN came up, but it was just very coincidental. There's a great book. Tony, can you think of it? It's called The Demon in the Freezer. If you ever want a great book to read, it talks about the whole process of how this organism was manipulated, how this organism got to the post offices, how these people got sick, how the laboratories first identified it, what happened to the public labs, public health laboratories afterwards. So very interesting book. I highly recommend it. It's called The Demon in the Freezer. It's done by an author by the name of Richard Preston. I can send that out to you afterwards as well too. Here, actually, let me just put it in here. Freezer, and what did I say? Richard Preston. So there you guys go. Any questions about what I've talked about so far? So you know that as you're working up your trigger points, the large gram-positive rod, ground glass looking non-hemolytic, motility is negative, your catalase positive. Obviously, we don't do these anymore. If you're still reading the old CDC book, if all of those things, if even one or two things don't match, you can rule it out. Just, I would say, have several things to rule it out, and you'll feel comfortable with ruling it out. So I'm going to just wait to see if there's any questions.